Well, hello and welcome to everyone joining us for the final Daria seminar of the year, which I'm sure you're all very sad about, but we will be back in the new year. Uh, Chris Tremonti's not with us today, so they've dug another Chris out of the department. And yeah, my name's Dr. Chris Davis, one of the addiction consultants at St. Vincent's. And I'll be sort of moderating today's session, which is about cannabis use in opioid treatment programs and people with opioid use disorder. I'd like to begin by acknowledging the traditional owners of the land on which I'm joining you from, the Gadigal people of the Ora Nation. And I wish to pay my respects to elders past and present, and to any Aboriginal or Torres Strait Islander people who are here with us today. Before we start the presentation, we've got an active Q&A function, so please put any questions you have as you think of them in the chat or in the Q&A room, and we'll get to all of those hopefully at the end of the presentation. We're starting today with Dr. Jack Wilson, who is a postdoctoral research fellow at the Matilda Center for Research in Mental Health and Substance Use within UCID. His current research focuses on the harms and benefits of cannabis use, as well as implications for Australian cannabis policy. And in his presentation, Jack investigated the long-term relationship between cannabis and opioid use, predominantly using data from the 18 to 20 year Australian Treatment Outcome Study, the ATOS. And Jack will present his findings on the longitudinal relationship between cannabis, heroin, and opioid treatment use. And then following on from Jack, we have Dr. Laila Parvaresh. She's an addiction medicine specialist and public health physician working at Southeastern Sydney Local Health District. She has a passion for both clinical care and research, and is concurrently pursuing a PhD at the University of Sydney, focusing on addressing cannabis use in opioid agonist treatment populations. Her research aims to investigate strategies for addressing cannabis use in the opioid-dependent population. This research projected was made possible by a regional grant at CESLID, but today's presentation is about the clinical staff's perspective and knowledge regarding cannabis use in opioid agonist treatment clients. And she recently presented this at ISAM in Morocco. So thanks very much to our two presenters, and I'll hand over to you.
Thank you so much, Chris. Really appreciate that. As Chris mentioned, I'm a postdoc at the Matilda Center, and today I'll be talking about some research from my thesis, my PhD thesis, which primarily aimed to investigate the long-term relationship between cannabis and opioid use disorder. Specifically, I'll be presenting on the long-term relationship between cannabis and opioid use, and whether cannabis use was associated with opioid use disorder treatment. Laila will then go and discuss her research, which further investigates that relationship between cannabis and opioid agonist therapy. So I'll just get started. So, I mean, a bit of background. I don't have to tell you all that globally, the number of people reporting past year non-medical opioid use has nearly doubled since 2010. And according to the World Drug Report, Australia are some of the leading consumers per capita, second to only North America. Now, this is particularly concerning because opioid use disorders or opioid dependence are a remarkably persistent condition associated with exceedingly high rates of morbidity and mortality. In fact, opioid-related deaths have exceeded that of traffic-related deaths in the US and are on par in Australia. So you're probably thinking, well, where does cannabis come into the picture? Why are you interested in cannabis? Well, the research suggests that cannabis use is quite common among those with an opioid use disorder. Cohort studies suggest that around 1 to 2/3 of people with an opioid use disorder will engage in frequent cannabis. And this may become more common as we witness a change in legal cannabis policies worldwide, both legalization towards recreational and medicinal use. Meanwhile, there's been recognition as cannabis as a substitute for opioid use by means of an alternative therapy of pain relief. And I think it's important to note that a number of US states have recently modified their medical cannabis laws to allow patients to substitute their prescribed opioids with cannabis. We're also seeing in Canada, they're having an inquiry at the moment into their Cannabis Act to see whether it could potentially be used as a substitute for opioids. And I think in addition to this whole substitution effect, cannabis may also be substituted for a high that uses seek in opioids, or as a way of managing opioid withdrawal symptoms. So obviously you can see the importance of cannabis, and it seems to be becoming more important as we go on. And I think this area sort of received a fair bit of attention in 2014 when a paper was published in JAMA that found that annual opioid overdose mortality from 1990 to 2010 was lower in US states with medical cannabis laws compared to those without medical cannabis laws. And this sort of difference in overdose deaths sort of increased as the years went on. However, there has since been an extension of an analysis using that data from that paper, and they found that this trend actually sort of it crossed back over. So that is to say that there appeared to be a 22.7% increase in overdose deaths within states that had passed the medical cannabis laws compared to those that had not. So rather than suggesting a trend reversal, the authors just stated that they thought that the deaths due to cannabis use, so overdose deaths due to weren't due to cannabis use, but rather due to a number of other factors. But since then, we've seen an increase in papers that have looked at, cannabis among those using opioid in cohort studies, which may improve upon those ecological studies and the limitations around ecological studies. And we also have seen this sort of interest in cannabis use among those in treatment for opioid use disorder as well. Therefore, the overall aim of this research was to improve our understanding of the long-term relationship between cannabis and opioid use throughout the life course. And I hope to achieve this by investigating the reciprocal relationship between cannabis and heroin use, and the impact of cannabis on treatment for opioid use disorder. And there's no sort of better way, to me, there was no better way of investigating this issue than using data from the Australian Treatment Outcome Study. And you may have recently heard some talks around this study. So to just briefly do an overview, in 2001 to 2002, we started ATOS, which was a prospective longitudinal cohort study led by Professor Marie Thiessen. And it is one of the very few studies that has a sole focus on heroin dependence. The ATOS study consisted of 615 people, 535 that were in different treatment modalities around the Greater Sydney region. And we also had 80 that weren't in treatment within the cohort. And just to give you a bit of a scale of how long ago the ATOS study started, when participants were first recruited, I had begun this large long-term love affair with bacon. And Russell Crowe he was winning Oscars, and we had this bloke as our Prime Minister. Since then, the ATOS cohort has been followed up at 3 months, 12 months, 24 months, 36 months, 10 to 11 years, and most recently 18 to 20 years. And as you can see, we've maintained quite exceptional follow-up rates for this population. However, there has been a significant increase in the number of participants who have died over the intervening years. And this is just to show that the 18 to 20 year follow-up consists of 3 components. The first one is a structured interview with our participants, which assesses drug use, treatment utilization, risk-taking behavior, mental health, physical health. And we also added a new component to ATOS, which just came about in the 18 to 20 year follow-up. And that's where a portion of our of our cohort were asked to do some physical health assessments at RPA Hospital. And lastly, participants were also asked to link their records with health data from the following databases. Unfortunately, we haven't really looked at the results from the second and third component, so I'll just really talk about the first component today. So at baseline, our cohort was fairly typical of people presenting for treatment for heroin dependence, which is to say that they were 2/3 male, mean age less than 30, almost all were heroin dependent by nature of the study, and had been using heroin for an average of 10 years. There was a fairly high amount of polydrug use, and 1/4 had major depression. At 18 to 20 years, the cohort was still 2/3 male, about 18 years older, with 1 in 4 having used heroin in the past month, and 15% were heroin dependent. Just under half were still in treatment for opioid dependence, which was primarily maintenance pharmacotherapy. Crime as the main source of income had decreased to 4%, and those experiencing unstable housing reduced to 2%. So for this analysis, our outcomes were past month use of cannabis and heroin at each follow-up, which was assessed using the opioid treatment index. And covariates included baseline demographics, other drug use, treatment for heroin dependence, criminal involvement, and physical and mental health. And the primary analysis that we used, and I think was sort of an improvement upon a lot of other studies in this area, was we used a random intercept cross-lag panel model, which is quite a novel method that allows us to understand longitudinal within-person relationships between 2 outcome variables over time. Now, the proportion of participants reporting heroin use more than once a day decreased substantially from baseline to 3 months, further declining through to 18 to 20 years. There was also a decline in the proportion of those using heroin daily and more than once a week. And at 3 months, almost half had abstained from heroin use in the past month, increasing to 75% at 18 to 20 years. And compared to heroin, there was an increasing in the proportion of those using cannabis more than once a day from baseline to 3 months. However, this was then followed by a reduction at 12 months and further declined up until 18 to 20 years. Now, to investigate the relationship between cannabis and heroin use between time points, we utilized what's called a random set cross-lag panel model. And to explain what this is a traditional cross-lag panel model, which is a method of analyzing the degree to which a construct changes over time. So for instance, whether cannabis use at time 1, up the top here in the green, influences cannabis use at time 2, and so on. And these are called autoregressive terms. But our cross-lag terms are looking at, whether cannabis at time 1 predicts heroin use at time 2, and vice versa. Now, the problem with the traditional cross-lag panel model is that it sort of assumes that there are no stable between person differences over time, which can then bias the conclusion. So to overcome this, we use what's called a random intercept cross-lag panel model. Now, this looks completely messy. This is just to say that this controls for between person differences, so that the remaining results are just are pertaining to within person differences. So to make it clearer, though, I'll present the results like this. And after controlling for a range of demographic, physical, and mental health, criminal involvement, and substance use factors, all autoregressive terms were positive for cannabis. So that is to say that an increase in cannabis use relative to a person's average use across time points predicted an increase in cannabis use at subsequent follow-ups, which is pretty expected, I guess. And this was also the case for heroin use, but not in the early follow-ups. And this is probably explained because, when we first recruited them, they're entering treatment. So that was when we saw that sort of rapid decrease in heroin use over time. In the first few follow-ups. Now, as for the juicy stuff, the cross-lag panel models, we can see that an increase in cannabis use at 24 months relative to their average use across time points was associated with an increase in heroin use at 36 months. Meanwhile, an increase in heroin use at 3 months was associated with a decrease in cannabis use at 12 months, and an increase in heroin use at 24 months was associated with a decrease in cannabis use at 36 months. So not really getting that reduction that some may expect, reduction in heroin use, rather the opposite at 2 time points. Yeah. So in conclusion, while the proportion of the cohort using cannabis reduced from baseline to 18 to 20 years, it didn't drop as much as heroin use. So it shows that cannabis use was quite common throughout the time points among the ATOS cohort, and an increase in cannabis and heroin use largely predicted further increases in respective use at their subsequent follow-ups, which we expect. Although this is not the case for heroin for early follow-ups. And there was some evidence to suggest a within-person escalation effect where an increase in cannabis use was associated with subsequent increase in heroin use, but I wouldn't really look into this much because I think the main message of these results is that while there was some signal of a relationship between cannabis and heroin use, this was sparse and not consistent. So I think the main message from our results is that there was no real consistent relationship between cannabis and heroin use over time. But cannabis may play a pivotal role among those with opioid use disorder via its relationship with treatment. And Laila will get into this a bit later. But just when we're looking at the ATOS findings, I think it could be really interesting to see that long-term relationship between cannabis and treatment over 18 to 20 years. So at each follow-up, participants were asked whether they had received treatment for opioid dependence for each of the 3 treatment modalities. So that's opioid pharmacotherapy, detoxification, and residential rehabilitation. And if they had received that treatment, the recency and duration of each treatment episode. And for analysis, treatment use was assessed categorically for each year for yes and no, coded as any days in treatment. And this data was then used to construct treatment trajectories using group-based trajectory modeling. A 5-group model provided the best fit to the data, and the 5 groups were categorized as long-term low treatment, rapid increase with gradual decrease, late increase, long-term treatment, and reduced treatment. Only one baseline covariate was found to be significantly associated with treatment group membership. And we determined that the long-term treatment group was more likely to be in maintenance therapy at baseline compared to the long-term low treatment group. In terms of 18 to 20 year measures, the reduced treatment group was more likely to report wage or salary and less likely to be in prison compared to the late increase group. And furthermore, the reduced treatment group was less likely to report past month heroin use and benzodiazepine use compared to other groups, but more likely to use alcohol actually. So overall, the cohort exhibited distinct patterns of treatment use according to the group-based trajectory model. And while the 5 groups significantly differed in terms of whether they were in maintenance therapy at baseline, their source of income, prison since last interview, and past month use of other substances at 18 to 20 years, cannabis use characteristics weren't associated with treatment trajectory membership. So in summary, cannabis use was common among the ATOS cohort and remained quite common over the 2 decades. And while there was some evidence to suggest that cannabis use may lead to an increase in heroin use, this was not consistent throughout. So we sort of determined that there was no real consistent relationship between cannabis and heroin use among this cohort. We also found that there was no evidence to suggest that cannabis use was associated with treatment group membership either. Thanks. I'll send it over to you now, Laila.
Thank you, Jack. Just let me share my screen. I'm finding my PowerPoints now. Okay. So today's talk of mine is about cannabis use and actually Australian treatment program clinicians' perspective about the cannabis use in their clients. This is a part of my PhD, which is specifically looking at cannabis use in clients who are on opioid treatment programs, meaning methadone or buprenorphine. And this research project was a collaboration between 6 different local health districts in New South Wales this year. So as Jack has mentioned, cannabis is the most common illicit drug used in Australian general population. Also, it's very well known to be associated with physical, mental, and social harms. And dependency with the cannabis happens in 10 to 20% of the general cannabis users. And we all know that cannabis use has been known to have some therapeutic benefits, as well as with medicinal cannabis is used for chronic pain, epilepsy, retractable epilepsy in children, palliative care, or symptom management in cancer, for example, nausea and vomiting. Specifically looking at clients who are on opioid treatment, cannabis is the most frequent illicit substance that is reported in this specific population. And this population reports last month's use of cannabis in around 38% of them. And 20% of these clients reports daily use of cannabis. And the study has been showing that cannabis used in this population, in comparison with non-cannabis users, they are more heroin users as well. They have higher rates of psychiatric disorders and social harms. For example, increasing incarceration time or family conflict or engaging in criminal activities. However, we don't know what really clinicians are doing with cannabis use in this specific population. And generally, as a clinician, our observation is that it's not a priority in our regular clinical practice to address cannabis use in opioid treatment clients or clients on methadone or buprenorphine. So we tried to do a survey, or actually we implemented a survey on clinical staff working in 6 different local health district public OTP clinics. And we tried to understand the attitudes of clinicians and their practices regarding cannabis use, because the hypothesis was that it's not a matter of urgency or a treatment matter for clinicians. And we asked them if they care about cannabis use in the opioid treatment program, and then if they care, what type of interventions they are implementing, or what type they believe we should be implementing in future, considering that cannabis is going to be very much in the future legalized in Australia, and probably is going to be picked up by our clients more than general population. So the participating sites were recruited through Drug and Alcohol Clinical Research Network, which included Southeastern Sydney, Illawarra, St. Vincent, Sydney LHD, Western Sydney, and Hunter, New England. And we received the ethics through Sydney University and Sydney Local Health District. And the eligible participants or the clinicians were the clinicians who at least were working part-time in clinical grants, and it was open to medical nursing staff, allied health, and pharmacist managers and client representatives. This was a very well taken survey in our clinicians. We successfully recruited 160 clinical staff, which is very good response rate in a survey. And in looking at it, actually our survey was attempted 190 times, but 5 were ineligible proceeding, 3 were repetitive responses, so they were omitted, and 20 did not pass the section 1 of the survey, which was social demographic. So in total, 162 participants proceeded to the survey. Looking at the social demographics who actually participated in our survey, we found out that mostly women participated, 62%, and the mean age of our participant was 45. And the nurses were more than 50%, nearly 50% of our participants, and the doctors, more than a quarter of the participants. They were mostly full-time workers and with the employment history of nearly 9 years in these clinical practices. So we ask about the pattern, what the clinicians think about the pattern of cannabis use in their clients. And what was reported by the clinician was that 56% of their total OTP clients were using cannabis in the last months, and 45% of their total OTP clients under treatments had cannabis dependency. And when we looked at specifically differences between the response rate in different professions, employment history, or their employment hours, there was not much of significance in the mean percentiles of the reported percentiles of the clients using cannabis, whether daily or 1 to 3 days a week or 3 to 7 days a week, or having a cannabis dependency. So they were very similar in the mean percentile reported. When we asked about the harms and benefits, or what did they see as a harm and benefit of cannabis use in the clients under opioid treatments, there were obviously some benefits reported, and the benefits were quite interesting because it is very similar to the benefits that is reported in general population through cannabis study. And about 50%, the clinician believed about 50% mean percentile of the clients are benefiting from cannabis use in managing their sleep problems, followed by mental health problems and chronic pain. And harms were much more easier to ask from the clinicians because this is what a clinician do in their usual daily practice, asking about harms of the illicit substances, for example, cannabis. And after obvious harm of dependency and addiction of using cannabis, it was more of psychosocial harms that were identified or highlighted by the clinicians in their clients. So they believed about 30% they have financial problems, and use of tobacco was mentioned as well, following the financial harms of using cannabis. So when we asked about what do they believe about the problematic use of cannabis use and types of the treatments that their clients were seeking, the clinical staff believed that about 41% of their clients have their problematic cannabis use. However, they said that only 15% of their clients said to them that they have problematic cannabis use, which is a significant difference between what they clinicians believe as a problematic cannabis use and what the clients are reported, based on the idea of the clinician, obviously. And they said that about 14% of the clients actually want to do something in future about their cannabis use, and only 11% of them did something in the last year for their cannabis use or address cannabis use. And most of them, the clinician believed that the most strategy that was attempted by the clients was self-directed strategies, followed by counseling, and followed by medicinal cannabis treatment, which is quite interesting because medicinal cannabis treatment is something that is not offered in OTP public clinics in New South Wales. So when we ask about what do they think about the future services and what we should be doing about cannabis use in OTP clients, they said that, well, obviously we should do more. 64% said we should do more to address cannabis rather than being client-led. And when we ask where do they think that we should be doing something about cannabis use in OTP clients, about 77% believe that we should be doing something in our OTP services rather than being referred to the external services. And when we ask specifically what is the details of these services that they are thinking about in future, they said that the strategy that they want them to be implemented in future in OTP clinics probably is harm reduction intervention, followed by counseling, and followed by medicinal cannabis again. And when we ask about how confident are they about implementing this kind of strategies in a future service, for the harm reduction, they felt quite confident. For counseling, they were somewhat confident. And for medicinal cannabis, they were not confident at all. And for medicinal cannabis specifically, when we asked that, where should it be used, they said that we should be using it for cannabis use disorder, strongly agreeing with this fact. And they said that we strongly agreeing with the fact that we should be using medicinal cannabis to treat other health problems in these OTP clients. So talking about medicinal cannabis, because it looks like that it's a pattern that is coming from clinicians about, and their interest is about the medicinal cannabis. We asked about specifically about medicinal cannabis, or how much they know and what do they know and what is the express needs by the clients. They said that 40% of their clients currently accessing prescribed medicinal cannabis somehow from somewhere, and 18% are actually inquiring about accessing medicinal cannabis. And when we ask them how confident are they about giving the advice to their clients about understanding the current rules and regulation about prescribing medicinal cannabis, they were not confident. And about how to access the medicinal cannabis, again, they said mostly that they were not confident about how to access the medicinal cannabis. And about their experience, they said that 90% of them never been included or involved in providing medicinal cannabis to any clients. So looking at medicinal cannabis again, we asked them how much they're concerned and what they're concerned about the medicinal cannabis or prescriptions of the medicinal cannabis in this specific population. They said that 74% of them were very much concerned about driving related problem, and followed by cognitive impairment and also cannabis dependence, which is quite reasonable concerns coming from a clinician prescribing medicinal cannabis. So we had a reasonable response in general to the survey, which is a great response rate. And our clinician reported that there are high rate of recent cannabis use and dependency in opioid treatment clients, the general population, and that was what we were expecting. The reason of the use or the motives of the use for our clients were identified by the clinician as being sleep and mental health and chronic pain, compared to other effects that they may get from cannabis use. For example, we know all about the cannabis opioid sparing effect or enhancing effect of other substances, or enhancing effects of their opioid treatments, but they were somehow rated lower than the benefits coming from sleep management or mental health management or chronic pain management. And there were some perceived harms as well, that social harms were quite outstanding, for example, smoking and financial issues after the obvious harm of dependency. Despite all of the above and the harms that were highlighted, only 15% of the clients believed that the cannabis use is actually problematic, and 14% of them wanted to address it somehow in future. And more than 50% of clients, clinicians believe cannabis use should be addressed because through strategies such as harm reduction advices, counseling, and medicinal cannabis, even though that they said they were not confident of implementing medicinal cannabis in a future service. And 77% believe that we should be doing medicinal cannabis in OTP public services. And despite having no experience, because 89% of them were never been involved in prescribing or even providing any medicinal cannabis. And they are not confident about how to access medicinal cannabis and what are the rules and regulations about medicinal cannabis in New South Wales or in Australia. So the take-home messages are that cannabis use is very in this specific population, as you know, opioid treatment population. Among clinical staff, there is recognition of potential harms and also some benefits and some reasons for use of cannabis in this specific population. And it's an important finding in our field because we previously considered cannabis as a harmful substance, but it looks like that it can be as a harm reduction strategy itself because it is beneficial somehow in chronic pain management, for example, or mental health based on what clinicians are reporting. But it's good, the clinicians are reporting about their clients. It's good to understand what the clients' opinion are about the cannabis use. So this is the next step that we are taking in future of implementing survey in the same LHDs, asking the clients, hoping for 400 participants and asking about the cannabis use and the potential benefits and harms, and what do they want to do in future about that. So this is the end of my presentation. I'm open to the questions, not only to me, but to the whole panel, I guess.
Yeah, thanks so much, Laila and Jack. It's fascinating, and cannabis is obviously such a common issue for all of our clients in OTP, and some really interesting insights. We have got a couple of questions, which is great. So I'll just put them to both of you, I guess. The first question is from Tony, who asks, did you get a sense of any other barriers to providing cannabis treatment in OTPs beyond low levels of confidence and knowledge in staff, and also the client's level of wanting to address it? Yeah, so what was
I think this is mine, but none.
Yeah.
So did you get a sense of any other barriers to providing cannabis treatment in OTP? Well, we did not ask specifically about that, but Tony, you are quite aware that there are lots of barriers at the moment with medicinal cannabis in Australia generally, because it needs a lot of rules and regulation to navigate for prescribing medicinal cannabis. And also there is not much of, except the TGA's criteria, there is not much of a defined criteria of what kind of product to use or in what conditions to use. And it really definitely needs to be addressed in future. And I'm hopeful that this, by the Greens bill that is coming very shortly in Australia and cannabis is legalized, we'll have more, barriers challenged by this. So yeah, it would be good to address that and identify more barriers, but no, I haven't asked.
And I mean, it seems like
more barriers of why people are not doing it.
It seems like clinicians were sort of suggesting that medicinal cannabis was a good substitution therapy or a way of withdrawing from street bought cannabis. But I don't know if Nick Linceris has joined us today, but there have been some studies about using medicinal cannabis for cannabis use disorder, but there's no guidelines or good evidence to suggest that's a good pharmacotherapy or a good approach for clinicians to be taking so far as I understand it. Did we get any?
Yeah, and I'm hoping that he will answer this question.
I'm not sure if you can unmic yourself. I'm not sure if Nick, or if indeed you want to, and certainly it sort of makes sense that with proper harm reduction and counseling alongside it, you could use cannabis as a way of weaning off cannabis. But yeah, as far as I know, it's not a reason to prescribe it yet, or an indication. Yeah, I'd love to unmute Nick. Can you do that, Dora? Let Nick out of the Zoom cage. I can't see the list of participants, so oh, here we go. Attendees. Maybe I can. I believe Nick does use medicinal cannabis to help people with cannabis use disorder.
Yeah.
Hello,
Yes,
can you
he
hear
does.
me?
Yeah,
And
Nick,
yes.
you're live.
Hi, everyone. The real issue is less about should we be prescribing cannabis for cannabis use disorder in an OTP population. That is one potential, inverted commas, indication, close inverted commas. But when we think about the high prevalence of comorbidities in our OTP populations of chronic pain, sleep, and mental health disorders, those are very frequent in our client populations. And those are the three most common reasons why any doctor prescribes medical cannabis in Australia: pain, mental health, anxiety, depression, and sleep. So even if you're not interested in a regulated drug supply, which is what prescribing cannabis is, let's be really clear, it's a step beyond decriminalisation and moves into the world of regulated supply. But even if you don't want to go there, the question remains, if a methadone patient or buprenorphine patient with chronic pain is medicinal cannabis an indication there? And I use the term lightly because there are no indications for medical cannabis in Australia. These are unlicensed products. So medical cannabis is not indicated for anything. They're all unindicated, so non-indications, because the drug's not registered. And it then challenges to also understand, is the cannabis use actually a form of self-medication? So are we seeing the high rates of cannabis use in OTP populations, which persist over time? And I think that's one of Jack's lovely data over time, is that this doesn't seem to shift a lot. Like, it sort of reduces a little bit, but not that much. So what's going on? Is that just addiction? Maybe it is. But have many of our clients already figured out that cannabis helps them with management of their symptoms, and they've been doing self-medication? And there's some of the questions that Laila will be addressing in her next survey.
Yeah, absolutely. I mean, is someone dependent on cannabis because it's an addictive drug, or are they using it because their chronic pain or their anxiety is not being addressed by other means, or they find that that's the best way to manage it?
This is the challenge we have, isn't it? Someone's been on a benzodiazepine for 20 years and says, "Doc, I need my benzodiazepines or I can't sleep." Are the benzos working, or is the patient become dependent to benzos and they get withdrawal if they go without them? And I don't think we have a good way of understanding that conundrum.
I think the difference would possibly be in the clinician's perspective, and I guess we get a little bit more worried as clinicians about benzo dependence than we do cannabis dependence. And I guess medicinal cannabis now being available can fuel that. You know, I think our patients now see cannabis, I guess they've always seen it as a medicine, and it is a medicine, but the fact that they can now get medicinal cannabis online or over the phone fuels that perception that it's a medicine rather than a substance. There's quite a few questions, and Nick, please stay on the line. There's a question about cost. Is medicinal cannabis the same cost? As far as I'm aware, the cost is very similar. Certainly, one of my clients was saying he can get it a bit cheaper from his dealer, but the dealer was not as reliable as the doctor. I don't know if you know any cost comparisons, Nick or Laila.
Well, I am not, I'm not, at the moment, I'm not very up to date with the cost of the market, but my understanding was previously, or very much after COVID, medicinal cannabis was expensive, specifically CBD, than the cannabis that is in the market. However, I have to say that you know, THC is possibly cheaper than CBD, and you know, but
So Layla's correct. It depends on what product. If someone though was purely looking at a high THC, say 25% flower product, then there are strains on the market which cost around $10 to $12 a gram, which is approximately the same price as illicit cannabis. There's very comparable pricing, but for a high potency THC flower, it's once you start adding CBD, then price becomes goes up considerably. If the patient wanted to be using a high dose CBD oil, just say, and using therapeutic doses, say 400 milligrams, then they're looking at $300 to $500 a week. So it's extremely expensive for the CBD. The THC though is very inexpensive.
But Nick, this looks like an Australia problem, because I don't know, in UK that I was recently in, it was CBD everywhere.
No, it's a universal issue. What you see in many parts of the world is CBD gets sold over the counter in homeopathic doses. So 10 or 15 milligrams a day, 20 milligrams a day, which we have no evidence. We don't understand what those doses do. All the research around CBD for a clinical indication to treat something like seizures or anxiety and so forth is always using doses of 300, 400, 500 milligrams a day, not the over-the-counter 20 milligram stuff. And hence why it's so expensive.
Yeah. Thanks, Nick. Josie's asked if any doctor can prescribe medicinal cannabis for well, I guess you've already said there are no indications, but Josie mentions chronic pain, and I believe you need to be authorized to prescribe.
No.
You don't?
Any doctor can prescribe, but dare I say, I don't really want us to turn this into an update on medical cannabis. We've got Laila and Jack who've done really great research, and maybe we could do another session one day at NCRED on medical cannabis if there's an interest in that. But I think I don't really want to distract from Laila and Jack's work, and I think, you know, we maybe just stop, you know, move on to some questions for them maybe.
Thanks, Nick. All the questions are around
cannabis,
prescribing, apart from your question to Jack, which I thought was really good. Can you see that question, Jack?
Yes, I can. Thanks, Nick. Yeah, I guess that's a great point with the OT. You know, Shane Dark sort of put it forth a while back, and I think that it has some benefits over a lot of alternative methods. So we asked them. We asked them about smoking episodes, and I guess we're talking about joints and bongs. So we are capturing that sort of severity of use throughout the day. But I would like to see, I've been working recently with Tom Freeman and some colleagues over in the UK towards a timeline follow back method for THC units. And I think a method like that would be really beneficial to sort of get that more potency, some of that more data on potency and consumption of THC. Another thing that I did add to the ATOS, the 18 to 20 year follow-up, is I asked them questions about different cannabis products, which they had never been asked before. And although I didn't present that data today, it was quite interesting to see in the past 12 months, you know, as expected, a large majority of them were using high potency indoor grown cannabis. But over their lifetime, low potency outdoor grown cannabis was more sort of traditionally used among this cohort, and we had very few people using concentrates and hash or resin, but yeah, so it was, and use of these products didn't seem to be associated with any other outcomes at 18 to 20 years. So I think that's some really interesting insight into the strength of the cannabis that they're using, and whether that's related to any other outcomes.
So Jack, did you get any qualitative research? Because it seems like you didn't find any sort of relation, particularly with the treatment patterns or amount of use. But did you get a sense as to what the consumers were using cannabis for and how they related it to their heroin use or treatment?
Yeah, I mean, I think we, although not formally, we did. I was able to keep my ears out and see what see what they thought about their cannabis use. Nothing, not as interesting to hear, but we had a mix. We had some people that had just been using cannabis for a long time, and they didn't really feel like it was related to their heroin use or other drug use. But then we had other participants that I remember. A participant said to me, she said, "It's swapping the witch for the bitch," and I remember hearing that and thinking, I'm gonna title a paper that. So yeah, we had a mix of feedback. Yeah.
I guess there would be, so some people would switch, or heroin use for cannabis, or at least use cannabis, I guess, to help withdrawals. So like on an individual level, there would definitely be a relationship that we didn't find on a population level.
Yeah, potentially. I think one of the limitations of our analysis is, and our data, is that we were unable to look at those different reasons for use. As you just said, Chris, people with opioid use disorder that are using cannabis are using it for an array of reasons, and unless we're able to really look into that, it's difficult to really make any conclusions around around whether cannabis is an effective, method of reducing withdrawal symptoms or an effective, method of reducing pain. I think so it really just forces us to sort of make an overall conclusion with this data, in that, it didn't seem, whatever reason they were using their cannabis for, it didn't seem like it was related to heroin use in the long term. And also, I'll just add that I also did that relationship so we also asked about their use of other opioids, so for non-medical use, and we found that cannabis was similarly not related to the use of other opioids as well.
Yeah, so I guess like with everything, we've just got to speak to the person in front of us and see,
Exactly.
what things.
Yeah, absolutely. Yeah, sure.
Yeah. And Laila, with your study, I know it was very much from the clinician's perspective, but there were 5 consumer workers who filled out your study.
Yes, they did, and they trickled down to 1 or 2 by the end of the survey. But I didn't look at specifically what the idea is, and I guess that it is very important to know the point of view of consumer workers in future. And this is going to be a part of the last part of hopefully my PhD, is doing a little bit of interviewing with working groups, including consumer workers and consumers, about how we are going to be implementing the identified strategies by the clinicians and clients to address cannabis use in opioid treatment. But in sense of the survey, because of the small numbers, I did not specifically commented on what specifically the answers for the consumer workers were, but they were included in other groups.
Yeah. We've just got another question come through about whether tobacco smoking was included in the study, Jack. So I guess when cannabis increased, the tobacco ingestion increase at the same time. Yeah, so are people always mixing tobacco with cannabis? I guess.
Yeah,
Did you look at
absolutely.
that?
That's a great question. Unfortunately, we were unable to capture that. But as expected, I think over 98% of our cohort smoked tobacco at baseline, and although this has decreased, it's still predominantly used among the cohort. But unfortunately, we weren't able to look at whether they were mixing their cannabis with tobacco, and if so, how much they were mixing their tobacco with. Although I do think that would be really interesting to sort of do a similar analysis, but looking at that long-term relationship between cannabis and tobacco use. Yeah.
It can be a way of starting a conversation about reducing cannabis, just because cigarettes are so expensive these days.
Absolutely, yeah.
That tends to be one motivation that all of our clients share. Candice G mentioned using lived experience researchers. Yeah, for sure. I guess lived experience is important in everything we do. The rest of the questions seem to be around medicinal cannabis, and which I think Nick has kindly offered to do a Daria talk on for us next year, which is great. Thanks, Nick. And I know Nick has done lots of webinars around this, so yeah, please look those up. But I think we're pretty much coming up to our 1 o'clock finish line. Well, yeah, and I'd like to end by thanking Laila and Jack for 2 fantastic presentations, which I'm sure are relevant to everyone who works in the OTB sphere. And we'll see everybody next year. So have a happy Christmas and a Merry New Year.
Thank you very much, Chris.
Thank you.
Thanks, Anna.
Thank
Cheers.
you. See you. Bye.
See ya.